only occurs in normal activity when you've reached the end of rotation of the atlantoaxial joint. We're not capable of on this side or coming to this side and do a glide backwards. So you could in fact construct a test. I don't usually worry about it, but you could easily just construct a test, because I could come round to there like that and hold it, and then I could know that I would be at the limit of the atlantoaxial joint motion, and then I could come on with Chris here and just sort of see whether I could get any more movement by trying to take the occiput forward a little bit more. Or I could just simply hold it there. Could you sort of slump down a bit, Chris, on that thing there? I could do this. All right. Now I could hold the atlas steady at that point so that I know no more movement is taking place at the atlas. And now I can do that motion there and have a look at the anterior glide that goes on between the occiput and the atlas. But the thing is that if that's missing, I don't think it makes such a big difference to all of this. The thing that makes a difference there is basically the movement at the AA joint, because it exceeds by such a great degree this little bit of rotation that can occur at the occipito-atlantal joint. But that's a really good point. So you've just seen me make up Lamb's test. Okay? We've always tested that forward glide, but it might be a good idea to just see when I've got all this locked over like that. And I've now taken up that last little bit of range of the atlanto-axial joint. Okay, now, can I get a little bit more motion at the occipito-atlantal joint, coming around like that? So you could either do a direct pressure, or you could just get hold of it and pull it out and see what happens. And then you could come to the backward glide, of course, on this side. Or I would probably do it by doing it a little bit more with my body, just coming back like that on this side. So that would let us perhaps differentiate between the loss of rotation at that joint. I've no facts to prove that, but it is a modification of a test we've done for a long time, which is just testing the forward and backward glide of the occiput on the atlas, which Evianth actually propounds.
I guess I'm confused about how, if you're side bending everything down to the side.
Yep.
Why, what is pulling the AA into that rotation?
I think it's probably done by muscle, or it's done by me holding the head and just taking this over, and just the passive movement of keeping this here is done here. But he could do that perfectly well himself if I just said to do this. And what's happening is the side benders here are working along with the rotators to this side, because this is a perfectly normal movement that we're doing, a habitual movement.
I had always felt that it was the tightening of the alar ligaments which would cause the movement at the OA joint, causing the OA, or the head to de-rotate on top of the axis. If you're side bending, something's got to have to be happening at the alar ligaments.
Oh, I'm not saying it isn't, but I'm just sort of, all I'm saying is I haven't even really discussed the consequences of all of this in terms of the structures that are doing it. I'm just saying that if you take it over to the left here, that's happened. Now we could perhaps consider what's happened to the alar ligament as this gets to the limit of its rotational range. Certainly the alar ligaments are controlling that rotation, but I don't know that they're a major factor, as it is if we did direct the movement from above downwards, when I think to allow that movement to occur, we've got to have some give in the alar ligaments. But you see, what you've done also by doing this, okay, we've got down there, and what's happened to C2? C2's gone the same way, hasn't it? Because it's gone on 3. And that C2 has rotated like that. So to slacken off, you might be absolutely right here as well. To slacken off the alar ligaments a little bit, perhaps you've had to go to this rotation. But then we look at this and we see that as you go here, he's perfectly capable of allowing me to get a lot of rotation back in that direction. Now, if the alar ligaments have been tense to do that, I shouldn't be able to get any movement in that direction. So I think this is just a concomitant of the way that we can actually do independent movement in this area. But certainly, if we're side bending the rest of the neck and rotating it, we've got to derotate that, otherwise the head will look over in that way. And that's what you see with a stiff neck. At the AA joint, restriction lost. But this will be a very important thing to do. It's important for a number of tests, and it's also very important as a manipulative position, because you could imagine that I could get into this position now, and please understand, I'm not suggesting you should do this in sitting, but I'll just do that. If I got Chris in lying and I held him there like that, I would be actually exploring the last little bit of rotation at the AA joint in that position. And so I could use that, and a little push there would get back the last degree or so of rotation at the AA joint going to the right. Yes, Bob?
Just in feeling this in my own neck, I know that when I'm limited in side bending to the right
Yeah.
because of tightness on the left side. So when I go to the end of side bending to the right, I have still plenty of rotation left. If this
Now, what we've got to ask you is, that is correct, isn't it? Do you understand what Barb's saying? If she's limited in side bend this way, just sit round straight, my dear. Okay, if she's limited in side bend this way, what's happened to the rotation? How much rotation has come in?
only as much as I side
A side bend. So she's still capable of a lot of rotation that way, because a side bend is limited. So to use this as a test on her, for the A, I'd have to only side bend this to the same amount, and it doesn't work quite as well there, because I've got to kind of judge a bigger movement on both sides. But she's got a perfect example in reverse of this. If she can only get down to there, that amount of rotation this way is not taken up so much, and so she gets down to there, and you can see there's a considerable amount more rotation than if we went to this side and get it right down there, where the rotation now has taken place, okay, much more completely to the left at C2 and downwards. Now she's got very little movement of the AA joint. But I come to this side, because we can't get right down, that's the limit, she's still got a lot of movement there, because it hasn't been taken up by the side bend rotation to the right in the rest of the neck.
So her limit, based on that, we would say that it was in those discal segments.
Oh yeah, sure.
But
Yeah.
then what does that mean in terms of locking out? It would seem that this would not be a good way to try to lock me out.
You couldn't do it. Yeah, you couldn't do it in you.
Yeah.
And anyway, that's not where your problem is, so we wouldn't be doing that at the
Right.
AA joint. Yeah,
Wondering
it
if
wouldn't be
you
good.
have a problem
Yeah,
lower down.
you've got to be able to get it way over for it to be of any value. Yeah.
So if you're going to use it for locking out, you want to make sure that when the person is at the end of side bending, there really should be almost nothing. Otherwise, you wouldn't want to use that for locking out. That's what
Yeah.
So when you're side bending, basically you're doing, it's basically it's rotation. If you're side bending down, let's say to C2, the limiting factors are going to be the shapes of the facets, or the facets opposing each other, right?
No, I think the limiting factors are everything. I think the limiting factors are the disc.
Would you agree, in large part, it would be the facets either in a rotation or in the side bending motion?
No.
You can have some limitations, obviously, on this side, but let's say all things being equal, isn't side bending and rotation basically are the same? Are
Yes.
the same thing in the cervical spine?
But it's not to do necessarily only with the facet joints. It's to do with the relationship between the facet joints and the uncovertebral joints.
Okay.
And the coupling is much greater in the upper two levels, that's 2, 3, 3, 4, than it is down at 6, 7, where the uncovertebral joints are much less defined. So it is a relationship of the whole segment. I'm really kind of unhappy about, ascribing in a segment various aspects, because I think we've got to take this as a 5-joint segment, the uncovertebral, the facets, and the disc, and everything is taking up strain as you do this. But certainly the coupling in the upper two levels, that's 2, 3, 3, 4, the upper discal levels, is much greater where there is a much greater development of the uncovertible. And that's what one of Chris's countrymen talked about, Penning, who did some wonderful work on the relationship of the uncovertible to the facet joints. Now, I don't know whether that was a red herring. I didn't answer your question, so now is the opportunity to readdress it, Bill.
Well, what I'm looking at, we talk about 47 or 45 degrees of rotation at the AA.
Yes.
We talk about the lower portion of the rotation or side bending, taking up the other 45 degrees.
Yeah.
At the AA, both in flexion and in side bending, you still can get movement. With the side bending here, it would seem obvious that you should be able to get this motion because you haven't used up your 45 degrees or 47 degrees.
Yeah.
Where on here, where I have a hard time is that one of the tests that we used to use to test the OA was very similar to the one that you were talking about, where you side bend right here, and if the person's nose kind of deviates down this way, when they side bend like this, they get everything pulling, and the alar ligament tightens. If the joint is free, it should be able to come back to the neutral position if you side bend the head. You do a volitional side bending, and that was one of the tests that we used to use for testing the OA.
Yeah, I'll have to. I'm not sure about that, and I wouldn't like to answer it just off the top of my head. So perhaps at a break we could kind of get a spine and just show me what the test is, and then we can kind of discuss it. Otherwise, I might give you a wrong answer, and God forbid I should give a wrong answer to this group, because I'll never live it down, especially as we're on tape. Okay. Any other things on this? All right, how did we go on first of all? Okay, inside tilt of the head, we've really sort of not really covered this one, so let's do it from the top downwards now. So inside tilt of the head, like this, keeping the face in the coronal plane, because this is going to illustrate one or two other principles that we need to do when we're manipulating as well. And this is why this is kind of good stuff to come up with. All right? So what happens at the C0, C1 joint inside tilt? We get the side bend there, don't we? Or the translation to the opposite side. All right? What do we get at the C1 or C2 on C3? If I'm doing side flexion, let's say, to the left, that movement there. What happens at 2 on 3? Left rotation, left side bending, because that's the couple. So what must happen if the face is in a coronal plane at the occiput on the atlas? An opposite rotation. Yes. So that's quite complicated. So that when we're looking at a stiffness, let's say at the seemingly of the head on the neck like that, we've got to have a look and see whether there is a side flexion of the skull on the atlas, a rotation to the left of the C2 on C3, and a rotation to the right of the atlas on the axis, because those are movements necessary to produce that simple motion there. That so-called simple motion. And when we think now, not so much of the motion done passively, but we think of Chris doing it himself, the amount of muscle work there of control to pull all those structures in the correct directions, notwithstanding we've got some ligament pulling as well, is really quite incredible. Simple little movement that we can give patients to do as an exercise once we've taught them how to do it properly. Okay, now the movement of the joints related to the curve of the active surface. All right? Everybody had trouble with my descriptive English there, so we're talking about how does the shape of the surface affect its movement. Right, Clay, how are we going to go on this? What's the answer to this?
At the OA joint, the condyles on the atlas are kidney-shaped. And the axis of movement's going to be, it's hard to describe, more back.
Okay, well, it's a male surface, isn't it? So essentially the glide is going to be opposite to the angular movement. Yeah, all right. Now then, when we come to 2-3, once again, no problem. We've got an active female surface, which is the same for the rest of the spine. So it's going to be in the same direction. What have we got at C1, C2?
Convex, not convex.
Okay, and how does that behave?
Ask me a little bit more specific, guys.
Well, if you've got at C1 on C2, when we go into flexion, what kind of a glide occurs?
I would say posterior glide.
So you've got it behaving the same as a male on a female surface. How about the rest of you?
Doesn't it just pivot?
So you've got it acting as a female on a male surface? No?
More like a fulcrum kind of action, doesn't it just?
So no glide. No glide.
I think doesn't it rock? Yeah, that's what I'm thinking. It's a
Roll.
rock and roll.
Well, if it rolls, there's got to be a roll forward or backwards. I mean, there's got to be a direction of this roll.
It has to, doesn't it have to pivot because of the, doesn't it just have to pivot?
Yeah. I think it's a very difficult one, this. Kapanji gets it going in the opposite direction, like Clay here. Other people have talked about this going and acting as a female surface on a male surface. Okay? And also, we've got this sort of little thing of the rocking. I certainly think that in terms of mobilization, how are you taking it? How have we been learned? You've taken it as a female on a male surface. But in actual fact, we've actually now accommodated Barb's concerns. Because instead of just doing what we used to do, which was to take hold of the head, do you remember the technique which was to take the forehead for the occipito-atlantal joint and take it backwards, like this? Then we came to this joint here and we used to pull it forwards, like this. But Evian pointed out that if we're taking the head forwards like that, what's going to happen here is that we're going to put quite a bit of stress on the transverse ligament, because it's going to take this surface forward in that female form there. So what he's suggesting now is that we kind of try and hold the thing against the dens and then tilt it like that a little bit, so we don't put an excessive amount of problem. So we are using a little bit more in our technique a rocking action like that, trying to retain the atlas against the front part of the dens like that, not let it slide forward in that way. So we'll practice that just to make sure that you've got the mobilization techniques really well with this area, because they're so important. Yes, Bill?
There's about a 30-degree inclination on in the direction of those sets in there. Does that affect also? Well, one, does it affect the way that you mobilize, and two, does it affect? Do you feel like it affects that motion up there?
Yeah.
Somewhat?
I'll answer that by saying it doesn't make any difference the way I mobilize.
Yeah.
Should it make a difference? I don't know. Can we mobilize one side or the other? These are sagittal joint movements. We know if we get a stiffness in one side, it's going to cause a rotation. If we feel a rotation is taking place as we come down into this is this business about, you know, I used to do a lot of this business, a lot of this analysis of sort of coming back into a movement like this and thinking, okay, if that's at the occipito-atlantal joint, and this is backward gliding here, and if this one is kind of stuck as I go forward, this one is going to come, sort of back on this side, and if I do the next one down, it's going to go to the side of it, and I never found it was accurate enough to formulate anything, so I abandoned it.
About turning the head
Yeah.
30 degrees and doing a straight.
A distraction, you can certainly do distraction. Yeah, yeah. And that's a technique that can be done as a manipulation and also as a mobilization. And I think there's a lot of value in it. Any other things on this? So we've opened a bit of a can of worms here. And hopefully we've perhaps not resolved a lot of things, but we've asked ourselves some questions, and I think we should try and utilize the principles that we've spoken of in terms of some of our techniques. Okay, and then I'll give you just a chance to get a drink or something, because we've been going for an hour and a half on this, and that's enough, according to Buzan. 45 minutes is quite sufficient for any lecture to last. So here you are, last little thing. Now, I'm going to ask Barb's group to do that, because she's got such a good and thoughtful group. And for the rest of you, we'll go with this diagram. All right, we'll go with this diagram rather than Kapanji's. What are all of those structures from 1 through 9?
Is the picture in the book now? In the handout?
I don't know. I don't think so. I don't think so.
I don't think so, yeah.
Perhaps it'd be a good idea to put it in though sometime. Although I think it's in some of the other books, isn't it?
Probably, yes.
Well, that was out of Van's.
Pardon?
That was out of Van's article.
Out of whose?
Van's. Van?
Yes, yeah, yeah.
I didn't know it was out of Van.
The next one is
W-E-R-N-E. Van?
six
Van.
is
You German? Yeah, probably. Well,
I thought it was Swedish.
could be, but
Yeah.
one is
German name? It may be. It came out in that Acta Clinicus Scandinavica, the article. I thought with a name like Sven, that's Swedish, isn't it?
Sven is Swedish.
Yeah, yeah,
Oh yeah.
Yeah.
I mean, he can have
Yeah.
German answers.
yeah, yeah.
But in Sweden, they pronounce it.
I don't know. I don't know.
Then it turns into the temporal memory.
We assume that
Yeah. I mean, Europe is bigger than
yeah, I
Where are you up to, Bob? You're ready? Oh, there you are, you see. That's why I was going to give you the more complicated diagram. Okay, Bob, get going. 1.
One is the neural arch, not neural arch, it's the anterior part of C1.
Yes, of the atlas, correct. 2.
2 is the anterior longitudinal ligament.
3.
3 is the apical ligament.
Yes.
4 is the tectorial membrane.
Possibly not. This is a bit confusing here. Look at 6. What's 6? Is a transverse, so that makes the upward continuation of the transverse ligament. No, this is just a sort of an ascending portion of the transverse ligament. Those are the accessory portions of the transverse. And then we come back to 5, okay, and that is the tectorial membrane, membrana tectoria, which is the upward continuation of the posterior longitudinal. Yeah. Then we have the next line back, of course, is the dural sleeve, which is number 9. Number 10. Yes, and it's called the clivus. The clivus. And we'll be coming back to the clivus because its motion away from the dens and its motion towards the dens, it determines what happens to those longitudinal ligaments in all these tests we do and think we know so much about things. It's kind of quite interesting because whatever tilt we put on the head is going to materially affect the tension in the apical and the other ligaments, the longitudinal interspinous ligaments. Okay, we go to 8, Bob. You're really on a roll.
We're thinking that that's probably the basilar artery, is that not? I couldn't
No.
figure out what that, I mean, 7, we weren't sure if 7 was the vertebral artery, we weren't sure what that was.
Yeah.
Or
Okay.
it's supposed to be a ligament.
Yes, it's a ligament. And so is 8.
Well, I'm not sure about what 8 is. That-
Looks like
Yeah.
ligament and flavum. 7.
Well, what would be the ligamentum flavum be called in this area? Yes, the posterior atlanto-occipital membrane. Not elastic, but that would be filling in between those where the lamina would be. And so 7 would perhaps be the deep portion of the ligamentum nuchae, or the interspinous ligaments at that area. That's excellent. So when we're looking at this, and we'll have a coffee right now, but when we're looking at this, these intraspinous ligaments we sort of concentrate on a lot. But of course, when we talk about flexion, extension, retarding those movements, the further away from the center of rotation that the ligament is working over a longer lever, the more efficient it's going to be. But these are the ones that we sort of spend a lot of time talking about, probably because they're interesting and also because they get injured. What doesn't appear on here, Bill? Which ligament that your favorite ligament?
Alar.
Yes, the alar ligament. So we just stick the alar up here. So we'll celebrate Bill here. Okay, we'll stick the alar ligament up here. We can see the apical, we can see the alar ligament, we can see the transverse ligament with the upward and downward bands, the cruciform part there, and the accessory atlanto-occipital axial ligaments there, which, you know, sort of complicate this because we don't know all the time whether all these ligaments are there. Certainly these accessory things. But it's very well protected, as it should be. Here we've got a lot of range of movement in a really tricky area. There's a lot of stuff in a small area compacted here from the skull, you know, everything coming into the rest of the body at this area where there's a lot of movement. That doesn't seem to be, you know, the greatest design. You'd sort of think you'd have a really major stable area here. And yet it's tremendous how it's all sort of packaged. And absolutely, I think Greg Grieve talks about this as being a wonder of modern packaging, or ancient packaging, I suppose it should be. And it is, when you look at this, how everything is organized. All right, let's just have a little stop for a while, and then we'll get straight on, because we want to at least have got the principles of manipulation in this area by the end of the afternoon. Some of these, just these anatomical diagrams prior to getting into the craniovertebral. Now, people have been asking me various things as far as some of the tests that you've done, okay? And it's probably a very good idea if any of you have had any difficulties whatsoever. There are 3 of us, all of whom disagree with each other, that can help you. Okay, so I think if there are any of the tests, various people have asked me about things, and I think we've kind of half resolved them to a mutual satisfaction. And so it's kind of good that we perhaps share these things out. So the 1 or 2 questions that were asked me, you know, Dan, that one that you did, and Ralph, that you asked me, that would be very good for us to just sort of talk to the group about. And then any other questions that have come up that you